My name is Eleanor Wakin. I'm the founder of the Dementia-Initiative. And on behalf of the Dementia-Initiative, I want to welcome every one of you personally, because you are doing the most important work. I know what you're doing. And thank you for being here to learn how to do it better. It's a hard job. It's not going to get easier, but we're hoping that after tonight, you will have a better sense of some of the beauty in this journey that you are taking together with the people that you love. The hospital is very happy that you are here because you are doing the work that needs to be done to give people a very high quality of life while they are alive, whether they have dementia or not. I have been reminded, incidentally, that anyone who is seated in this part of the room may be videotaped, because this program is going to be streamed onto our web pages. So if there's any person sitting in this area that prefers that they not be videotaped, that area right there is where you need to be. And I see lots of people are there and lots of people are here. Without saying much else, Lisa Lee Keith from Cooley Dickinson Hospital is going to welcome you on behalf of the hospital and tell you what this initiative means to the hospital.
Good evening, everyone. Good evening. It is so wonderful to see such a large group here. It is Friday evening, and that's not typically when you'll see a lot of people come into a forum. How many of you are new to the first time that the Dementia Initiative is at this forum tonight? The first forum that Eleanor, as a founding member, had was absolutely packed also. So for me at the hospital, and I'm going to introduce myself, I'm the Chief Nursing Officer at the hospital and the Vice President of Patient Care Services. Truly, to see all of you here from our community lets me know that we have tapped into something so vital for you and your loved ones. So I just am so overjoyed that we can partner with the Dementia Initiative and welcome you to this hospital to hold the forum, as well as to get to know what are the needs that you have, what is the education, the information, and most of all, how can we link better and better with you? Because care takes place 95% of the time in your homes with your loved ones. And we only care for your loved ones a little bit at the time when they're hospitalized. And how do we do a better job communicating with you and caring for your loved ones when they're here with us? So I truly welcome all of you. This is going to be a wonderful, wonderful evening. I'm going to turn this over to my colleague, Jean Ryan, who's the Executive Director of our VNA and Hospice at Cooley Dickinson Hospital.
Good evening. Maybe it's redundant to say, wow. And could people raise their hands again if this is the first time here? You weren't here on the 11th? It's really amazing because this started a year or so ago based on Eleanor's experience and what she wanted to do based on her experience with a loved one with dementia. And it started out in a room with a couple of people talking. And this room is filled with people. So obviously, you really hit a chord, Eleanor, and I really want to thank you on behalf of the whole community for what you're doing. And later on, she's going to yell at me for that because she said very clearly to me many times, this is not about me. So I just want to say that. I also want to introduce Michael Bardsley. He's in the back, and he is our organizing director. So thanks for that, Michael. We really appreciate it. You know, as the executive director of the VNA and Hospice, we are with you We're here to assist you, and we know that you're doing the work in your homes. And part of assisting with that work is getting as much information as possible. So we have a great lineup tonight, 3 great speakers who it's my honor to introduce. I'll start number 1 with Deb Dixon. Deb Dixon is first speaker to my left. Deb has been a registered nurse since 1984 and a psychiatric mental health clinical nurse specialist since 2004. She's worked on an inpatient psychiatric unit for 18 years, specializing in adult patients with a variety of mental illnesses, including dementia with behavioral disturbances. She has also collaborated with Tina Champagne, occupational therapist, in several research studies on utilizing weighted blankets in adult patients with psychiatric illnesses. To her left is Kathy Service. Kathy has also been a nurse. Kathy has been a nurse practitioner since 1979 and is also a registered nurse since 1973. Over the years, she's developed and sharpened many skills, which include listening, collaborating, negotiating, and working with numerous individuals and groups of diverse ages, skill levels, and roles. She has also presented internationally and written on issues of aging, intellectual disabilities, and dementia. And to Kathy's left and my left, we have Claudette Smart. Claudette has been the Caregiver Specialist Elder Care Advisor for Western Mass Elder Care Incorporated in Holyoke for over 4 years. Funding for the National Family Caregiver Support Program is through the Federal Administration on Aging and the Executive Office of Elder Affairs. In her role, she educates and encourages a healthy caregiving experience for the caregiver as they accompany their loved ones through their journey of dementia and Alzheimer's. So thank you so much for coming, and we'll get started.
The way it's going to work tonight, each of the 3 speakers is going to make a presentation of about 15 minutes. And each of you has a sheet to take notes on. After those 3 presentations, you will be swimming in information, and you will take a little break, walk around, have a beverage, use the restrooms if you wish, which are out in the anteroom. And then we have a microphone set up right here, at which we're going to invite you to come as questions from your notes seem like they could be answered by our 3 presenters. And you'll come to that microphone and ask your question, and the person or persons who think they can best help you with an answer will begin answering. But what we found the first time is that you are also the experts. And there may be in this room many answers among you. And so you may find yourselves as an instant support group for each other tonight. And if that happens, that's wonderful. So let us start with Deb Dixon, who's going to tell you about the various forms of dementia, how they present, how they develop, and how to tell what you're dealing with.
Hello, everyone. I'm grateful that you all showed up tonight, and hopefully we get to answer a lot of questions for you. Just a broad definition for dementia: it is a mental disorder that includes functional decline, cognitive impairments, behavioral issues, and also some psychological issues. So that's a broad definition of dementia, and that basically covers all of the different types of dementia. I did put on the board here all of the different types. It's dementia of Alzheimer's type. It's also known as Alzheimer's dementia, so you'll see it both ways. Vascular dementia, Lewy body dementia, Pick's dementia, Huntington's, Parkinson's, dementia due to HIV, and dementia due to head trauma. I forgot what I had put there. So those are all of the different types of dementia. Believe it or not, in the next 50 years, the number of adults that will be diagnosed with dementia will be 1 out of 45 adults. So that's pretty daunting that there's going to be a large number of us that will be diagnosed. That's just one little tidbit. The other thing is with dementia, in order to deal with the different types, the best way is to find a good medical evaluation and also a psychological evaluation, because each one is a little bit different. Some are very difficult to diagnose. So the first one I'm going to discuss is Alzheimer's dementia. Again, the cause for Alzheimer's is still unknown. There's several different theories out there. One of the main theories that they're thinking is a cause are the amyloid plaques and the neurofibrillary tangles. And basically, the way I've kind of conceptualized in my head to think about these tangles and these plaques is that you've got roadblocks in your brain that are causing the communication of all of the neurons and to not communicate with one another. So I've also thought of it as at the airport, the tower is not able to connect with all of the planes that are in the air. So what ends up happening, they're detoured to different airports. But also what happens is you've got these roadblocks, you've detoured or you get into tangles and you can't get out of that. So again, the communication is broken down. So that's sort of a nutshell or way of thinking of Alzheimer's or dementia. So dementia Alzheimer's is a gradual onset. You have early, middle, and late stages. So in the very beginning, the person is going to be forgetful. They might not remember that they called you an hour ago. They may forget that they didn't balance their checkbook. So there's a little confusion that may happen. They may also confabulate, which means they will discuss things and look at how you're acting towards them and kind of looking for you for cues as to how to answer a question. So they will give you all sorts of different answers that sort of sound that it makes sense, but they don't really make sense if you really sat and thought about it. In the middle stage, they start to lose some of their function. And again, these are just very broad, early, middle, late. Some of it can come a little bit earlier than other times. It really is very individualized, but this is a basic how things will happen for the individual. So as they, in the middle stage, they start to have the wandering. They might go into your room, take your underwear, take your shoes, or go into your kids' rooms and take stuff, fold it and put it in their drawer, because they don't really know. And that's what happens in the middle stage. They also start losing some of their coordination. And in the late stage is when they start to have the inability with the swallowing or inability to walk. They also start to have difficulty with like sitting on the toilet or knowing even how to sit on the toilet. They don't recognize many of the utensils. They don't recognize what a comb is, a brush. So that's happening in the late stages of Alzheimer's. Vascular dementia, and I'm going to go over all of them very quickly. So with vascular dementia, for that is, you can think of anyone who has a stroke is more likely to have vascular dementia. Anyone who has disruption or interruption into the blood vessels of the brain, That's going to be a vascular dementia. It's an abrupt onset, so they're fine today and tomorrow they're not. It's also an irregular pattern in the decline, so they may have some good days where they're very lucid, they know who you are, they know where their belongings are, they know where they are, who you are, and they don't have any problems, and then the next day they're totally different and they're very confused. So that's the one thing about vascular dementia. They will also have one-sided weakness, they'll have difficulty with their speech, they'll have a lot of emotional outbursts. And again, it also depends on where in the brain the vascular dementia is occurring. So if it's the frontal part, the front part of the brain, they're going to be very disinhibited. So they will be more likely to just take their clothes off wherever, and so that may occur just because of where the damage is in the brain. Lewy bodies dementia. With that dementia, it shares a lot of symptoms of Alzheimer's and also Parkinson's. It's a progressive degenerative decline. The symptoms do fluctuate. They do have moments where they're functioning well and they remember their loved ones, and then other days they do not. So their attention span and their inability to concentrate will vary and fluctuate. They may also have visual hallucinations, and they have the shuffling gait that Parkinson's, people with Parkinson's disease have. They're also, towards the late end, they have difficulties with coordination, and they have tendency to fall quite a bit. It's also difficult to diagnose at this juncture. They have to do a lot more testing, CAT scans, PET scans, in order to really diagnose the disease. Parkinson's, what ends up happening for the Parkinson's patient, in probably 25 to 40% of the Parkinson population, their illness will progress into a dementia. And so their symptoms are similar to Alzheimer's, but will be a little bit milder. And their thinking, their memory is a little bit slowed. They're a little bit more passive personality than someone with other dementias. And they also have a lot of trouble with decision-making process. So that's Parkinson's. Huntington's is a genetic illness that's very, it's progressive, and those who get Huntington's disease get it around 30 to 40, 50 years old. That's sort of the age where they're diagnosed with Huntington's. As they progress, they do get into a dementia, and they can be, have many behavioral issues and become very agitated and very angry because of their illness. Not only is it genetic, but then on top of it, they've got the dementia and they become like the Alzheimer's, but it's a little bit worse for them. Dementia due to PICS, that may be genetic. I was looking at some of the research, and some areas are calling PICS also frontal temporal lobe dementia. So you might see it labeled as both, or, and so it's hitting the front part of your brain and inside. So again, with that, with PICS, they're going to have a lot more disinhibition that will occur, a lot of personality changes. So why is mom or dad or my brother, who was a nice person, all of a sudden being mean and nasty, and that's why it's where it's hitting in the brain. The other type is the Creutzfeldt-Jakob, or it has different pronunciations depending. It is rare. It's a neurodegenerative disease, And the thought is that it's caused by a transmissible virus known as prions. It's affecting the brain, and it's something that is there. The symptoms can develop at any age, but they usually see it later in the 40s and 60s, excuse me. It is a rapid course, progressive degeneration, and death will occur in about 1 year. It's time. Excuse me, I'm going to take a drink. And a lot of the first symptoms are memory impairment, just like with Alzheimer's. They get depressed, very agitated, and they do have problems with movement. But again, it's very fast moving, so the decline is very quick. Folks that are diagnosed with HIV, some of them do get dementia, and so they have a lot of changes in their behavior. They have visual hallucinations, confusion, just like some of the other dementias. And again, it is depending on where the illness is occurring for that, the part of the brain. Those people with head trauma, dementia, again, their dementia, their symptoms will be based on where the trauma is to their brain. So if it's the frontal part of the brain, they're going to be disinhibited. They're going to be doing a lot of things that we normally don't do. And one form of a head trauma dementia is, if you think about the boxers like Muhammad Ali, he has a boxer's, actually right now I think he has Parkinson's, but he may also have a boxer's dementia going on. And they have muscle and coordination and very impulsive. So the next thing I wanted to just quickly go over is if the person, the loved one, is agitated, why? Is it due because they have pain, pain in their elbow, their shoulder, knees, wherever? So if they have pain, and they may not be able to express it, so you have to really look at what's their face saying, and look at that. And maybe look to see, are they clutching a body part? And if they are having pain, you can give them Tylenol or whatever the doctor prescribes for that. Is it because of urination? Are they having difficulty urinating? Do they happen to have a urinary tract infection? And unfortunately, many of our dementia folks have either urinary tract infections or they will have upper respiratory tract infections. So you have to really look at, is that a cause? Or is there another reason why they're agitated? And it could be something different for each person, but these are the main reasons why they could be agitated. Another thing is they could be agitated because you're saying no to them, when if you don't say the word no, not that you're going to just give them whatever they want, but try and say no in a different way, so that way it doesn't sound like you're denying them something. Because then they get agitated and then you have a lot of problems. And then for treatment, as you know, there is no cure at this time for dementia, any of the types. So the only thing that you can give someone with dementia is medication that will delay the progression of the dementia. And those medications are Aricept, Exelon, Namenda, and Rimonol. And other things that people with Lewy bodies, those people with the Lewy body dementia, they cannot have any of the antipsychotics, antidepressants, or benzodiazepines, which is the Ativans, Valium. because they have some very serious side effects when they take those medications, so they shouldn't be treated with those drugs. Many other dementia patients will have antipsychotics or maybe antidepressant. They might have a sleeping pill that's ordered, maybe like Ambien or Sonata, one of those. Excuse me. I'll take another sip. So, and again, what they're going to do is the antipsychotics hopefully will be used for some of the behaviors that they're exhibiting, and the psychiatrist will usually start at a very small dose of an antipsychotic, because you don't want to give the elderly person something that's too high, because they are greater risk to fall if their antipsychotic is too high. Other drugs that sometimes are used for their behaviors, like for vascular dementia, would be obviously treating whatever the vascular issue is. So it could be a high blood pressure med, it could be a beta blocker, many different drugs that vascular or cardiac wise that they'll be using on top of the Aricept and then Namenda, etc. They also sometimes will use Inderol for some of their behaviors, and also if folks are doing a lot of, they're very disinhibited and they're very sexually oriented in some of their things that they're doing, you know, touching, grabbing inappropriately. Sometimes physicians have used Depo-Provera, which is a hormone, estrogen hormone, so that way that will decrease some of that sexualization that the older adult has due to their illness. Sometimes it helps and sometimes it doesn't. And basically, treatment should be individualized to the person and not just definite, this is what you're going to give. Okay, thank you.
Thank you. I was listening as you were to all that news. It wasn't good news. And I remember that when I was the caregiver for my husband, I didn't want to hear any of that. It wasn't going to happen to him. I was going to be the one that wouldn't let it happen. And I know how you must be feeling now, hearing that kind of news. But now you're going to hear a different kind of news. You're going to hear some good news. The good news is going to come from Kathy Service, who's going to talk to you about the ways in which a person with dementia can still have a high quality of life, and the ways in which you can help that to happen. Because even though we do know that the disease progresses and the health and the length of life is going in this direction, there are many, many things that we all as caregivers can do. Kathy's going to talk about them to keep the quality of life of your loved person high and higher. Kathy, welcome.
Thank you, Eleanor. Okay. I have a lot of information that is in one of the handouts. So what I'm going to do now is most of it will generalize, give you some ideas, and I like to kind of put it into a certain context. So before I get started, I'd like to ask you if you divulge my humor here, okay? First of all, does anybody here speak or read Mongolian? Okay, that's good. The reason I'm asking you to do this is because I want you to imagine that you're taking up in an airplane and dropped off in the middle of Mongolia, all by yourself, okay? What would that be like for you? Scary, yeah. What kinds of things do you read? How do you read your environment? How do you know if this person's a friend or a foe, or I have to worry about this person? Body language. Facial expressions, tone of voice. Okay, so the reason I'm asking you to have this little exercise is because this is what it's like for somebody who has dementia. They are a stranger in a strange land, and if you have dementia, it's like you can't leave that land. It's like you're in Mongolia and you don't know, the language, the writing. Sometimes, occasionally, you'll see McDonald's. So just like if you were in Mongolia, you see McDonald's, you start to feel a little bit more comfortable because it's something familiar. That does happen when somebody has dementia, too. So the behaviors, or what you see people exhibiting who have dementia, are not intentional. They're on an emotional level. And the other thing I want you all to remember, too, is that you really need to communicate on an emotional level. That part of our brain that governs our emotions is intact until very end of the disease process. So you're not going to be able to reason, rationalize with somebody and saying, oh no, this is not how, we do things, or you can't do that, as Deb was saying. It doesn't work. Unfortunately, it just doesn't work. So try to look at when a person is showing different things, try to approach them on an emotional level. What are they really trying to say with their body language and whatnot? So that's what's important to remember about working with people with dementia. So, and no matter what the situation is, the reality is that how you interact is crucial. So how should you interact? And I'm going to be honest with you. My mom had vascular dementia, Alzheimer's dementia, and I provided respite for her on many occasions. And so sometimes I used to say, I'm supposed to be this expert on Alzheimer's disease, and I'm a real failure, when I was taking care of my mother. So, and just to say that, it's not always easy, but these are some things that can help you kind of make it through the day. First of all, is that really Alzheimer's dementia, or dementia in general, is really not a great disease, and it's kind of interesting that it happens in our society because we're such a fast-paced society, and we expect everybody to be intelligent, communicate intellectually, etc. And unfortunately, that really doesn't work with a person with dementia. So when you are interacting with a person with dementia, you really need to kind of slow yourself down, okay? And it's not easy when you're in a rush, I tell you. So you really have to kind of make sure you approach the person from the front. Don't scare people. Don't, making sure that you have, eye contact with that person. Try to be down have eye contact at that level. And move slowly. I mean, the reality is jerky movements. It's like, can you imagine, like, if you were in Mongolia and somebody just had a fast reaction to you? It's scary. It really is. And you don't know, what's going on here. So that's one way. I always used to use that sort of analogy to kind of help me guide my actions with my mother. The other thing is that, excuse me, give people time to answer and respond. I mean, and it's interesting, is this that Deb says, you've got these, amyloid plaques are like grease balls, and for Alzheimer's disease in your brain, and they're like road detours. And sometimes people can respond, but it takes them an uncomfortable amount of time for a response. So, that's one thing to be aware of. If to try to allow people the time to respond. The other thing is try to limit different options. Putting things in a positive manner for people too. Instead of saying, oh, don't do that. Say, well, let's do this kind of thing instead. And you also need to, you can expect a lot of repetition. I think people will ask the questions over and over and over and over and over again. And it can be really exasperating. I mean, I told you, and I thought, you know, sometimes I told you we're having this for supper or something like that. And you know, you have to kind of get some, you know, check yourself at times because it can be very, very difficult. Never get in an argument with a person with dementia. All your rationalizations are not going to win. One night when my mother was at my house, she was insisting to go home, and home to her meant where she was born and brought up in Chicopee. So rather than saying, you know, you're home, blah, 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 I said, all right, you know, I'm not going to get in an argument with her, so go outside. And there I am. I live close to downtown Northampton. So approaching Main Street with this little old lady in her walker and me, I was like, Ma, you know, going the wrong way. And finally it started to rain, so I said, I think we better get back, it's raining. So we went back home. So, but I didn't argue with her. I figured I'm not going to have a fight. It's not worth arguing about. And then she went to bed after that. I mean, it was those kinds of things that you kind of make some decisions about and try to work with the person. The other thing that is important that I found, and it's a hard thing for a lot of people, is when people say things and you feel like you need to lie to them. You know, for instance, if they're asking, or my mother asked me to go home to Chicopee, and I'm like, you can't go home, they told me to go. You know, and she's not going to believe me. She'll argue with me. What you really do need to do is when you have something like that, you really need to kind of focus on what's the feeling behind that. She's asking about going home because for her, home means security and safety, and it means something important to her. So try instead, don't say, you know, oh, we'll go home later. I mean, sometimes people feel, I used to feel kind of awkward using these, what somebody had mentioned one time as fiblets, like telling little lies. You know, anyway. So what you do is use some distraction or focus on what the feeling is behind that. Just say, you really want to go home, so tell me about home. I don't, you know, and you know probably exactly what her home was like for her, but they can, you know, they'll tell you good stories and stuff like that, and sometimes this distraction or way of thinking about them will you know, help you manage the behavior. So it's things like that that are important. You also, as I said, emphasize the positive. Don't say, don't do this. You also, when you speak to somebody, and I have a hard time because I kind of rattle on, is use very simple sentences. You know, a noun and a verb. It's like, come here. And one of the things also to do is use your body too, you know, when you're trying to say something. You know, come here, or let me help you put your coat on, and hold the coat up for the person. It really kind of enables them to do things. I know this might seem kind of basic, but sometimes, you know, these things happen, and even just holding the coat up can kind of jumpstart an automatic reaction. And I think, you know, some other things like Deb was talking about with utensils and eating, you know, there'd be times when a person, you know, won't recognize on the food on their plate and stuff, and if you just stick their fork in it and get them started, that's memory that is like what they call rote memory, and it's ingrained in you. They'll be starting to eat just like they would normally eat. So different things help at different parts of the disease process. So that's, it's also important to find, you know, conversation that you can talk about and things to do with a person. You know, hugs. Just because a person, the other thing, just because a person has a dementia doesn't mean that their medical problems go away. what it means, what you need to do also when communicating is be aware of the environment. And when I say environment, I mean both the internal environment of that individual. What's going on with them? Are they, as Deb was saying, are they agitated because they're thirsty? I mean, it's hard sometimes, to be honest with you, to kind of imagine like somebody not being able to go up and get a glass of water. We just do this so automatically. And when somebody has dementia, they don't have that connection there. So I think it's little things like this, is trying to kind of go through all these kinds of things. And it's not to say that anytime you do something, things don't always work. Sometimes things work, sometimes they don't. You have a bag of tricks almost to try different things with people. Along with environment, the internal environment, you also need to look at the external environment. What's going on? Is it light enough? Is it light enough, that person, or is there shadows there? I mean, people. I know people that with shadows, they think they're ghosts around, or something, or a hole or something. So how we see the world isn't as they see it. So I think that it's hard for us to kind of imagine and get into that space because it's a whole different world. And I'm not going to go too much onto behaviors. There's a handout on it, but a couple of the hints that I give you about behaviors is to, just make a determination. Is this behavior a nuisance behavior? It's like keeping asking you, is it supper yet? Is it supper yet? That's not going to hurt anybody else. It does get you exasperated, I'll admit that. But, you can answer back again. The dangerous behaviors are things like wandering. And have the environment. The environment can be your friend. There are a number of things that you can do to modify the environment so that your home or where the person lives can be safer. Using color, contrast, different things like that. The other thing is really just to kind of work with the person on, as I said, is just on the emotional level. Because that part of who we are, we're always the same person inside. And I think that that's important to remember. And I'll just kind of conclude my portion here talking about my mother again. My mother was a farmer's wife, and she was kind of salty, as people would say. And the thing about the dementia and her dementia, what happened is that, she never told me that she loved me growing up and all whatever. But when she was sort of in the later stages of her dementia, she said that she loved me. So, when Eleanor talks about embracing or just trying to accept things and understanding things, I was blessed with that. So if anybody has questions, we'll take them later.
Kathy, thank you. The best thing I ever did with my husband was to love him. I held him, I held his hand, I kissed him so much, I don't know if my lips came off. And I want to tell you, that works. When somebody has dementia and they're frightened, they're frustrated, and they are embarrassed, and they know that they're in trouble, the best thing you can do and the most natural thing that you can do is just what dogs do with each other. Just sniff them and lick them and love them. It goes so far, it makes so much difference. And doing that both rejuvenates the caregiver and also exhausts the caregiver, because the caregiver doesn't get a break. And what happens is that we become wonderful caregivers for the person who's receiving the care. But little by little, we forget that we have to take care of ourselves. And so many caregivers get sick. They get stress-related diseases. And with any luck, their body will hold out at least as long as their care recipient does. It is a terribly hard job to be a caregiver. And Claudette Smart is here to talk about how we can take care of ourselves at the same time that we are taking care of the person that we love.
Hello, everybody. Good evening. Good to have you here. I am really excited to be here. I think I have one of the best jobs in the entire world because I'm a caregiver specialist, and the only people that I focus on are caregivers. Even though when I go into the homes, I do say hello to the elderly, but the caregiver, they are always the unforgotten people. Nobody, in our field, we work with people who are 60 and over providing in-home services. So every person who comes onto our service has a care manager or case manager. But the caregiver in the home has nobody. So when the case manager goes in, he or she will always focus on the elderly, but never remembering to say, hello, how are you doing? So when I make a phone call to a caregiver and I say, I'm coming to see you, they are elated. They can't believe that somebody remembers them. So that's why I think I have the best job in the whole world. And as caregivers, I just want you to know that you are beyond diamonds and that we appreciate you. We love caregivers, and we know it's a very tough job. So I'm here to talk about your health and how to take care of yourselves so that you can better serve the elderly person or your loved one. Of course, a caregiver, I'll define that for you, is not necessarily the person who lives in the home. Because some people do live in the home, but you might be a daughter-in-law, a husband. Well, if you're a husband, you might live at home. But you're a family who lives outside the home, and you have to work. But on your way to work, you have to stop in and see your mom or your dad or your loved one. You have to be sure that they're being taken care of. You're off to work. After work, you're on your way home. You have to stop again to make sure that everything goes well for that person. So you become a caregiver also in the realm of things that we have to offer to caregivers. So we encourage you to take good care of yourselves. And the only way to take good care of yourselves is to, in your packet there is a chart there with a briefcase on it, and there are some pointers on there that 15 minutes will not do it for me, because when I see a caregiver, it's a 2-hour visit. But I'll use 15 minutes to see, and I know you already know everything, most of it about caregiving. But your health, make it a priority. When you're taking care of someone, basically, you don't remember yourselves. Especially when the person with dementia or Alzheimer's is in the late stages. By the time you're up in the morning, you have to give that person their medication, give them a bath, do everything. By the time you get ready to get in the shower for yourself, it's time to take care of that person again. It's either lunchtime or toilet time or something. So you forget to take care of yourself. If you're on medications yourselves, you forget to take your medicine. It's 3 o'clock and you said, oh my God, I didn't take my medicine all day. But it's time to get a person up again for another toilet in or some food or something. So it's constantly going. You miss your doctor's appointments. One of the reasons most caregivers, they have no backup for them, so they can go to their doctor's appointments. So they said, okay, I'll forgo my doctor's appointment and stay with my loved one. And then, it goes on 3, 4, 5, 6 months. You have not made up that doctor's appointment. So we encourage you, and I'll let you know how you can go ahead and get some help so you can make connection with your doctors and so forth. We ask you to take it one day at a time. It's easier said than done to take it one day at a time, because every day is something different for the caregiver. Because your loved one changes most of the time. Today it's not what they do tomorrow. And then, you become frustrated because you're not quite sure what to do. Not in an angry way, but sometimes you just throw your hands up. But we ask that you take it one day at a time. Learn to know your loved one and yourselves. And as the disease progresses, you will find that you have little cues on how to take care of that person, and like Kathy said, when to say no in a nice way, or yes, or what to do. And that's taking care of yourself. I'm here to talk about, to share your feelings. One of the hardest things is to let your neighbors know, or your family know, even your physician know. A lot of times we take our loved ones to the doctor, but we won't even tell the truth. We won't let them know what's really, really going on. We cover things up because we don't want people to really know. But it's so important that whatever comes out of you, it makes you feel better about yourself, because when you keep it in, it causes more stress, and then you become, more agitated, sometimes a little bit angry and resentful because you don't talk about it. So we encourage you to share your feelings with, of course you can't tell everything sometimes because you feel that you're being judged, or your loved one is being judged because someone does not understand what Alzheimer's is. So they'll judge you. But it's very good if you can find someone to share that feelings with, because from experience, when you talk with someone, sometimes you haven't laughed in a while, but you might say something and that person says something back and you just laugh about it because you need that medicine. It's a part of caregiving that we ask you to share your feelings. When you take care of someone who has, as you all know, especially in the middle and late stages, you know that the person who wanders or who wants to stay up all night, the caregiver lacks sleep. And think about yourself not sleeping for 48 hours because your loved one decides that I'm not sleeping. And it does happen that your loved one, they will not sleep and you're getting no sleep. And even if you do get sleep, you have to listen for that person. It's they're getting out of bed, they're going downstairs, they're turning on the bathtub, they're going in bathtubs, they're turning stove on, they're opening the door. So you can never get a full night's sleep because you're always on alert. And caring for someone with Alzheimer's as a caregiver, it takes its toll on the caregiver because, when you have a young baby, you look forward to growth and the growth is coming. But when there is Alzheimer's, the person, is not progressing. Like you said, there's no cure. So they only get worse as the years progresses and they go through their journey. So we ask that the caregivers try to get some rest. And the only way to get some rest, really, is to accept help. If you can accept help, which is one of the hardest things to do. As a caregiver, we think that we are the only person who can care for a loved one because we don't trust that person. And my loved one needs me more than anybody else in the world. And I'm the only one who can comb her hair, dress her, and prepare her meals and everything else. Even when someone else is in the house, because you have that love and you feel that you know, I have to take care of my loved one. Nobody else can do it like I do. But the goal is that you try to accept help if the help is there, and if it's someone that you think is trustworthy with your family, you know, your family members, then you can use them. And of course, you're still going to go upstairs and lay down. You might not shut your eyes, but you're laying down. You have one ear downstairs and you're just meditating or relaxing. And if you hear something, you know, you can get up. But it's good to get away sometimes. So I say that you should accept help. Now, caregivers in general, I met one woman this week, and she has not gone on a vacation. She has not taken a vacation in 7 years. She lives apart from her husband, even though they're married, but she lives with her mother. She left her matrimonial home, moved in with mom, and leaves work every day and goes directly to her mother's house to take care of her. Now, she had no idea that there help for her. There's some resources in the community for her that if she didn't want to leave someone in the home, that she could get her mom into a short-term facility so she could take a break. So just to let you know that taking a vacation and sometimes for some pleasure and leisure is very good for you. It's very healthy for the caregiver, because after you leave and you come back, you know, you start all over again, but you know, you feel different. You'll miss your loved ones, but at least when you come back, you'll start all over again. So I encourage our caregivers to take a break. And we do provide some type of services for the caregivers to take a break. Then take advantage of everything that's in the community for you. As caregivers, sometimes we tend to say, oh, we don't want to take hands out. But honestly, your loved ones, most of them, you know, they've worked all their lives, they've never taken anything. They qualify for some services that they don't have to pay for, which I'll tell you more about. You tap into those resources. Find out what's available. Adult day health, if you can get your loved ones in adult day health. Probably you might not be able to pay for it, but there are resources that you might be able to put them there to get a break during the daytime so you can you know, do something else and just get away. For those veterans, there's the VA services, and the VA does pay for adult day health and other in-home services also. So if you know that, you know, you have your loved ones, and you can tap into the resources in the community, because we want you to be as healthy as possible. Because as caregivers, when you fall down, there's no one to pick you up. And then if there's no one to pick you up, then who is going to pick your loved ones up? In other words, you might be an only child or the only caregiver who's providing the care. So that's why it's so important that you take care of your loved one and yourself, because you are the most important person in this relationship. Because if you don't take care of that person, you know, most of us don't want our loved ones to end up in a long-term care facility if we can help it. And that's why there are services also that can provide long-term care in the home for you as a caregiver, that, you know, you can hire someone, and you know, they're funding also for that. So also I'd like to talk about a contingency plan. I don't know how many people in here, I know we have healthcare proxies. A lot of us have our healthcare proxies. A lot of us have our power of attorneys. But how many caregivers think about, oh, what if I get sick tonight and I had to go to the hospital. Who would be responsible for my loved one? A lot of times we don't think that way as caregivers, because we have the other, the power of attorney and everything else, but that one thing is missing. If you could not get out of bed, who is going to come over and help to make breakfast for your loved one? Nobody, because you didn't make one. So we encourage all caregivers to find someone, have a contingency plan, and talk to the person ahead of time that I would ask you, please, would you be the person if I was not able to take care of my loved one for 5 hours until a relative get here, would you be willing to come in and sit with my loved one? So they wouldn't have to then come in with an ambulance, take your loved one out the house, take them to another facility or something. So it's very important that you develop a contingency plan so you'll have that to work with. I encourage you to think about your emotional and your physical well-being. You are a complete package, and we depend on you to take care of your loved ones. So you have to take care of your emotional, your physical, and your, if those of us who are spiritual well-being, in order to be wholesome, we need to be healthy. You have to get lots of rest, eat healthy meals, and if you can, exercise. Even in the house, just walk around a little bit, read a book, take some time for yourself to rejuvenate, because your loved ones will need you. And safety, I like to talk about safety to our caregivers also, because a lot of times we don't think that we're doing everything for our loved ones, but we don't think of all the little pieces that makes it healthy for you as the caregiver. So if you have someone that you're unable to get out of bed, don't try to do it with your back on your hands. And if you can get equipment for it, find out how you can get a piece of equipment to transfer your loved ones. Because one of the last thing you would want to do is to drop someone. But if you can get equipment, Medicare provides some equipment. Just to let you know that there are services such as the Mass Health programs. They're not just, because some people say, oh, Mass Health, I'm not eligible for Mass Health. But most elderly people are qualified for Mass Health through different types of Mass Health programs. So my last thing to you is that you as caregivers are survivors. You are the survivors. Because at the end of the day, when you have gone through the journey with your loved ones, you've done the best that you can, you've loved them, and like Eleanor said, love is one of the most important things in that relationship, because you're happier and your loved one is happier when there is love, and they do know when you love them, and they do know when it's a negative comment, even though they might not be able to come out and say it. So sometimes that's why it's so important that as caregivers we just take a break and allow someone else to come in and help you if you can. And as I looked at the statistics in Massachusetts for 2009, you are a part of that. In 2009, there were 234,000 caregivers just for Alzheimer's. And from that group, they provided over 500,000 hours worth of services in the home. And from that services, of course, they didn't pay the caregivers in the home, but the value of that was way over $3 million. And so because of that, we do have what we call the Caregiver Support Program, and it's a national program. It's called the Family Caregiver Support Program, and it was originated through the Older American Act, and it's a free program that provides respite services, financial support for like wheelchairs, grub bars, and other supplemental things that you can use in the home. So if you have any questions later, I'll be happy to answer them for you. Thank you very much, and please do take care of yourselves as well.
And so we have one person at the microphone, and then I have a question that I will ask, and then we'll go to anybody else who wants to come up, just come up to that microphone, okay? And if you have a follow-up question, feel free to do the follow-up question.
Thank you. I have a question about how to talk to my 85-year-old mother about medication. I think she's got a little vascular dementia from a couple strokes. She lives independently with her husband, but nobody, including her husband, can convince her that she hasn't won all the sweepstakes offers that come to her house. And in fact, she sent several $1,000s to a scam artist who said she'd won a greater amount of money. So she can't balance her checkbook, but that's about it. She's okay other than that. But you had mentioned that this Aricept and so on might be helpful for somebody with vascular dementia. I think if I say the word dementia, I think she's going to freak out. I mean, she thinks that there are some changes due to the stroke, but I don't know anything about the medications and how they would help, and I'm wondering if you could make some suggestions on how to talk to her about it.
That can be tough. Medications is a tough issue for many people with dementia. Sorry.
Or do you want me to bring this over?
Medications is a very big problem for many folks with dementia, especially if they're in the middle stages. Can everybody hear?
No.
You have to go real close.
Real close, okay. And it varies with each person, so it's very individualized how you talk to the person. Some things that we have used when I used to work on the psychiatric unit is trying to tell them why they're taking the medication. So you may not want to use the word dementia. You may want to say, it'll help with your thought process. It'll help you to think a little clearer. It'll help you with those periods of forgetfulness. So you're not really telling them what the medication is for. That's some of the tricks that we had used when we were having some dementia folks on the unit.
What does it actually do? I mean, my mother's very well educated. I mean, what would I don't even know what it does.
It makes there's a deficit in one of the neurochemicals in the brain, and it makes it much more available for the brain to use. So it operates, it's kind of complicated. I don't even know how to kind of explain it, but it does make acetylcholine at least those 3 of the medicines does make acetylcholine more available for use.
Thank you.
A question that I had from somebody who doesn't want to be on the camera is, are there times when the person with dementia knows that they have dementia? Or is it usual that they do not know? what's the change is, does that change as the degree of the disease progress? So it's a sort of, the question is around how aware is the person who is going to?
In the very beginning, they know that something is not quite right. That, and that's where they will start to confabulate. You might ask them, well, what did you do today? And then you'd say, oh, well, I called Lucy, and I went here, and I did that. And it all sounds quite believable, but they didn't do any of it. So they'll tell you some things that will be very believable. In the very early stages of dementia, but it doesn't matter which type, they are also susceptible to depression. So they can have a depression on top of their dementia, and so you have to treat that depression. They're going to be depressed because all of a sudden they're forgetting things. They're not sure, well, why am I forgetting where my keys are, or they're looking for a piece of paper and they can't figure out where they put it. So they will have depression in the early stages because they are, all of a sudden things are changing for them. You know, it's like just being dropped into Mongolia. You don't know what's going on, and so it's very depressing, and so that's also happening for them. They also, on top of it, can have a delirium on top of their depression and their dementia. So that's why that handout was given to everybody, so you can kind of see the differences.
You want to add to that?
I just wanted to say that one of the things is important is that people will automatically just make if somebody has confusion or a change in behavior, automatically say, oh, it's probably dementia. But there are many, many other things that one can get as they get older that can look like dementia. If somebody has a hearing loss or somebody's cataracts, they may be acting really strange, and it just needs their ears cleaned out. It really is important before a diagnosis is made that all kinds of correctable conditions be ruled out. There's a number of things that can happen. And it's not to say, also, as Deb was saying, is that even as a person who has a dementia can get an infection, and their symptoms may worsen. So it's things like that. You'll have to kind of be almost like a private eye, or be really alert, knowing the person. You know the person. You know the person you love.
I can bring the microphone around. Thank you.
First of all, thank you, all three of you. It was extremely informational and helpful to hear your suggestions. My question is that, are there ways to encourage a person with early to maybe moderate dementia to cooperate with you in the things that well, for instance, with depression, it's very clear to me that he gets more depressed the more he sleeps and the more he doesn't do, and the more he lays in the chair. And it's such an emotional struggle for me, and physical struggle, to help him to see the benefit of that. And I don't know, maybe there isn't anything, but I'm just having no success. I wondered if there were any suggestions.
Well, one of the things is your approach. It's like, let's do this. And I know this sounds kind of simplistic, but here, that's me, happy service, happy go lucky. Come on, let's go do this, And so, I mean, it may not be your own personal style, but I think, in an encouraging way, in a positive way, is try to engage the person to do things in a positive way. Even, get the code or whatever, and let's do this. And it really, I think that your attitude, because I mean, I'm not sure in terms of, because you're feeling badly, you see the person that you care about in a low state, and they're depressed, so it's contagious. And so unfortunately, you become like that. And so, they may be reading, some language that you may not be aware that you're you're giving them. I mean, it's incredible, you know, it's like sometimes you think, oh, I'm using the right words. Oh, yes, let's do this. And, but, you know, the tone, your feeling tone, it's incredible. It is like Eleanor, as Eleanor was saying about, you know, because it's like with a dog. I mean, dogs can tell, and, you know, babies, they can tell, you know, what's really going on. And it's not that I want to compare people to that, but that sort of basic kind of instinctual, how you work with people is the way to go.
I'd like to, does it work?
Yeah.
Yes?
Very close, very close.
It's very close, okay. I would like to speak to your question because I cannot count how many times I said to my husband, if you could just cooperate. And his answer to me was, I am cooperating. He wasn't cooperating. And here's what worked for us. I tried to use all the strengths that he had as a young person and as a very functioning adult. And so anything that I knew he was able to do well once, I found ways to try to do more of that with him. Is it your husband?
Our dad.
Your father, okay. If your father had any mechanical abilities, please get him some tools, get him some switches, get him that jump box.
Just a little funny thing, his profession was a dynamiter, so it's like... I just had to tell you that.
For everyone here who has that same problem, who is saying, can't you please cooperate, I'm doing my best. Once I said to my husband, who had been sitting in the bathroom for over an hour, I got down on my hands and knees. I said, I am begging you, please, this is not good for you. And he looked at me, he said, that's not dignified, get up. The best things I did with my husband, I went to Walmart and I got a toy basketball hoop, and he played hoops. We got the kinds of balloons that don't break easily. We got a badminton set, and we played balloon tennis, and boy, he beat the hands off anybody. I got bean bags, and we used to try to make a penny move on the floor. We took walks. He was a writer. I gave him endless magazines that were going to be thrown out anyway. He would tear them to shreds, and we would make collages out of them. Find ways to do what your person used to do with them again in whatever way they can do them now.
I'd like to, in my field, we encourage a lot of socialization. So a lot of times, you know, the person who's experiencing that memory loss, like Eleanor said, they want things to do. That's why we encourage, and the Older American Act also encourages adult day help. If that person is capable of going to adult day help, but we don't expect you to just throw them in. You go with them to adult day help, make a visit, and when they get there, there's so much probably in the home, you know, they just need to get away from their environment. But once they get to adult day help, they might like to do something with their hands. They have everything there for them, and they're very socialized.
Yeah, as we're talking, I just want to kind of bring up the use of humor. I think that's really important to have that. It's amazing how, you know, just listening to Eleanor's story and, I mean, and your...
My sister wrote my dad a poem because we have a 2-hour lapse of taking his pills every time it comes to a pill session. And it takes us 2 hours of saying, Dad, can we take another one? Dad, can you take another one? And I'd really like her to say the poem, because it's something that he reads and now has started to take his pills better. So you can say what you wrote for him.
It's very short.
It's very short, it's just a couple stanzas.
My father is a mighty man. He blows up rocks and hills. He will do anything he can, except for taking his pills.
Every time. And he laughs at it, and then he takes a few pills. So it's shortened from 2 hours to 1. But Yep. But it does work.
My name is Glafira. I'm an outreach worker at the East Hampton Council on Aging, and I will have intakes of the caregiver who finally has made the call, realizing that they need the help, and we'll have conversations, and we'll meet up with people either from Highland Valley or such. The thing is, though, afterwards, it's the person they're taking care of that will tell them that nobody but the caregiver can take care of them. So could you please give us some of the tips that you use to get the caregiver to be able to have the conversation about somebody else being able to take care of them? Because sometimes the caregiver will they'll call back to follow up, and they've just either felt guilty or just too exhausted to cope with it. Thank you.
Well, like I said, of their caregivers, we feel that we are the only ones that can do the job. And sometimes, in my experience, is that the caregiver, especially if they're families, some family members really do not want to assist at all. So the caregiver feels a responsibility to take care of that person by themselves, because, and especially if the person, the elderly, moved in with a daughter, that sibling out there has no part, because they feel that you have something to gain as the caregiver from the parent, so they don't want to assist. Is that what you're asking?
No.
What are you
No,
asking?
I mean, when the caregiver, okay, is willing to accept help, but the person that they're taking care of feels that the only person that can take care of is the caregiver.
Oh, well, then,
yeah, that's just
we cannot force any services on a person who does not want. So if the care recipient does not want someone else, there is nothing that we can or you can do. We cannot force them. I don't know what else to do.
What other way tell the caregiver to tell the,
to say that I need some help, focus back on yourself and say, I need a little bit, or I need to do this, and let's, but.
I have that problem. Most people have that problem. And what I would do is, after I had interviewed somebody a million different ways to make sure that they were somebody that I wanted to have help me, I would invite them in, and it would just be a social visit. And we would sit around the dining table, and we would have a social visit, and we would find out all the things that we had in common, and it would simply be, how nice she came to visit us. And then I would say, I'm going to invite her again. I like her. I want to have more time with her. So then I would invite her again. And after several times, I would say, I need to go to the store, but she will be here with you. And I used to give my husband a lot of notes, written notes. Could he read them? Who knows? I put them on index cards, and I used to write to him, I'm at Stop and Shop. I'm upstairs sleeping. I'm on the porch. At night, I would give him the card that said, your teeth are sleeping overnight. One of the things he was most concerned about was the fact that the teeth were not in his mouth. He was very insecure about that. So every overnight caregiver knew to give him the card and read it. Your teeth are sleeping overnight. And sometimes we even had to bring the cup to show him and then not have him put them back in his mouth again. But I found that introducing caregivers as friends was the way that helped me.
We have termed these forums as community conversations. And if somebody wants to respond to one of the questions based on their own experience, if you make it as an I statement and this is what's beneficial, I would encourage people to share like it's already been done. So if you hear a question and you say, oh, I could contribute to that answer, I want you to feel free to do that as well.
Two things. First of all, on the activity, I'm in a position where my mother stopped doing things before I even was in. She sits in a chair. She doesn't like to go out of the house. She was a florist. It was in the backyard. When my father died, she continued on. She remarried and continued on. When my stepfather died, she sat in her chair. I tried to get her down to the lunches. Unfortunately, I was out of town and my sister set it up. It was a disaster. Absolute disaster. She will not go back. Getting her, she has one meeting she goes to a month with a group of friends that she continues to. Other than that, she will not turn the television on because she never did that in her life, no matter whether she did or not. She won't listen to the radio during the day because I never did that before. So I have no way other than staying with her 24/7, and I'm sorry, I can't. You know, I can't be in that room with her 24/7. It just, with the noise that comes out of her, the moaning and the groaning, and it's what's wrong, and nothing, I'm just moaning. It eats at me. This has been, I believe it's stroke-induced because it's, a lot of the dementia started after a parietal stroke. And then she took a fall this summer that really had a, well, she had 4 staples in her head. Would that count as a traumatic brain injury? It broke her neck. Yeah, so we've got a lot of issues going on. I moved in with her, so it's her house, even though I grew up there too. Notes, she stopped reading. So I'm identifying with a lot of this stuff. So, help!
Eleanor wants to respond.
I hope other people are going to jump in too. One of the things that helped my husband a lot was a dog, a stuffed dog.
She has a real one.
She has a real one? Okay. Sometimes when the patient is a woman, a baby doll, particularly a baby doll that makes eye contact, can be a lifesaver. You can bring a baby doll and make sure that it has the kind of eyes that really look at you. Bring the baby doll in, and I don't know at what stage of cognition your mother is, but you can take care of that baby doll, talk to it, and then every once in a while you can say, would you take my daughter, my granddaughter, whatever you want to call it, would you take her for a few minutes for me and see whether she can form an attachment? Because many times people with dementia will form strong attachments to baby dolls and think that they are their daughters or their granddaughters. My husband thought that the stuffed dog was a stuffed dog, but he played along and it became his constant companion. So it's something to try. Who else has some ideas?
Does she respond to her dog?
Oh, yeah. Oh, yeah. Last week, she, on a good day, she actually took the dog out and walked up the street on her own. I don't know, it was maybe something my brother said to her on Sunday. But today, she could barely walk around the house. She doesn't like to drink. She forgets to drink. make sure she has a full 2 cups with her medicine morning and night. But it's, you know, we have a pendulum swing that goes from absolutely nothing to barely functional, and I'll get the, why are you treating me like an idiot? And it should be, you know, I don't know what you want me to do next. I have to give her one task at a time. Okay, here's your medicine, here's your water. Well, why can't I have a banana? You have to finish your water before you have the banana. She takes thyroid medication. If I give you the banana, you'll stop drinking the water. And it's one thing at a time.
And, you know, I mean, if it doesn't work out at that moment, you can, and with thyroid med, it's just taken once a day, so you have the whole time of the day to do something like that.
But then I give her juice, and she forgets to drink it. And I notice a big difference in confusion levels when she isn't taking the food.
But as a caregiver, I'm not quite sure what town you live in, but if you need a relief from caregiving, at least for a couple hours per week for a few months, you can contact your area agency on aging. They have their caregiver support program, and they should have some respite funding for you. So I'm not quite sure what area you live in, but I have the numbers, and I can give them to you, or if she knows that. They should have one.
Oh, yes, we're with
Hi, I'm Elaine, and I've been in this area since 2008, and it was hard enough for me to find a primary care in Massachusetts. It seriously was. And my mother's geriatric doctor is in Springfield, and she's going into a different kind of medicine now. We just got a letter. So one of my questions is, how do you go about finding a geriatric doctor in this area? She also was diagnosed with, well, the way it started just very quickly is we got her an MRI in 2007 when she was diagnosed with mild cognitive impairment. We went to a place called Memory Wellness in Springfield, and she's got a diagnosis now of vascular dementia. And listening to tonight, which was really interesting to hear all of you, and I appreciate it, I'm not so sure that she has vascular dementia, because she didn't have a stroke, and she didn't come on suddenly. She doesn't have an irregular pattern in declining. It just doesn't sound right, but she's got the same memory meds that that you mentioned. So I'm looking for a geriatric doctor. I'm also wondering if there's any new drugs on the horizon, because in 2007 the neurologist said there are new drugs coming out in about 5 years. So just curious.
I'm Beth Warner. I'm a physician who worked with Cooley Dickinson for a while as a hospitalist, and I've been on a leave of absence pursuing geriatric fellowship training, returning this summer to back to Cooley Dickinson. You are right that there is an amazing shortage of geriatricians, and not a lot of hope that there's going to be a lot more geriatricians in the near future. That being said, we're hoping that we can train the existing medical workforce to have better understanding of geriatric-related conditions, including dementia. My role come the summertime will probably be in a consultant role. I don't think I could do primary care in addition to all the work we have to do here in building geriatric and palliative care programs right now. I do presently work with the geriatric primary care center associated with Bay State, which if you want to know about that. Yeah. Meanwhile, I can tell you more about that later.
But yeah, there aren't a whole lot of geriatricians here. There are some primary care physicians who tend to have more of the geriatric patients that you could ask around, you know, who sees who. As for your other question about, does my mom have Alzheimer's, does it have vascular, it maybe doesn't seem classic for either. There's also a heck of a lot of overlap. You can have Alzheimer's and vascular. And you don't necessarily have to have had documented strokes to have vascular dementia. So I couldn't tell you, you know, without seeing your mom what she's more likely to have, but there is a lot of overlap as well.
It seems like it doesn't matter because the memory meds are the same. There aren't that many.
That's true. The medications do have a greater efficacy in Alzheimer's than they do in vascular. It's a little bit more data with that. With vascular, sometimes we think about working on the vascular risk factors as well. What's the blood pressure and the cholesterol, things like that too.
So I just wanted to confirm what you said so people heard it. So starting in July, you'll be back here at Cooley, Dickinson, and you're a board certified.
Right now, board certified in internal medicine and palliative care and soon to be geriatrics as well.
So I want to make sure folks didn't miss that. So you'll be back here for geriatric services starting in July. So just to answer your question. Thank you.
So I, Bruce, and then I'll work my way back here, and it is 8 o'clock, so I we'll move along. I don't want to keep us too much longer. Will you let people know who you are?
Sure. Yeah, my name is Bruce Bradley Gilbert. I also work here at Cooley. There's a lot of people here from a support group that I facilitate. But Claudette, this is actually a question for you in particular. I was really struck when you used the word, it's a journey, kind of a developmental journey. And in talking with tons of caregivers in the area, well, first of all, everybody here does not fit into the two categories I want to describe. You guys are amazing to be able to face this stuff, because it's big stuff. But I find the extremes are either intense denial, I'm not going to go there, and a lot of people find family members, other family members are doing that, and they're kind of left to the brunt of the work. Or the opposite extreme is paralyzed fear and emotions. And in some ways, I think my question was answered, especially when Eleanor was talking about the use of humor, but also all three of you used the use of storytelling and metaphor to try to kind of make sense of all of this craziness. But I guess I wanted to hear more about, you know, how can you manage all the spiritual and the existential kind of grief without being in denial or without being paralyzed by fear? Or angry.
Well, you know, caregiving, it's a choice sometimes, because I cared for my husband in a very special kind of way. And I didn't feel that it was an obligation. I felt pure joy and love. And I took care of him for a long time. Yes, he did not have Alzheimer's or dementia, but he had a stroke and was total care. So, and I cared for him for 6 years. I quit my job and took care of him. And I didn't feel nobody else could do it for me. Nobody else, even though I tried. So some people, they feel obligated, or they feel that, I can't find the word that I want to say, but they feel that guilty to take care of their loved ones. And because they feel that guilt, they do it. And the denial part for me is that if you cannot face that some of the caregivers said, oh, she does not have Alzheimer's. I have a client, and I've had her for 4 years. She's been taking care of her aunt. And every time that this woman calls me, she said she knows exactly what she's doing. She knows exactly what she's doing. She's doing it on purpose. She's doing this on purpose, but yet, she said, my uncle asked me to take care of her, and so I'm doing it. But I cannot convince her, even with the Aricept and all the medication and all the changes that we have seen over the years and have reported it, she still denies that her aunt has. So some people, you know, they just cannot accept it. Acceptance is a powerful tool. So when you can accept something, then you'll move on.
I too have some frustration about whether or not my mother has the right doctor for her. And his approach is that it doesn't make any difference. She's got something, dementia. There's no point in trying to determine exactly the nature of it. But at the beginning of the talk tonight, you said that it is important to have a complete medical evaluation and psychological evaluation. So I guess my question would be that, how do we go about getting that? I mean, it probably would take changing from her current doctor, because he sees no value. I've accompanied her to her doctor's visits perhaps for the last decade, and I kept telling him that, you know, something's going on, and we have family history. Like 5 of her siblings died of Alzheimer's. He said, so what are you going to do about it? If she has it, if we diagnose her with it, what are we going to do? He doesn't believe in the medication, so there's been really no treatment. And in his defense, my mother was not a good patient. Prior to this, she liked to avoid doctors, and as long as she didn't tell them anything was wrong, she thought there wasn't anything wrong until I came to this. So I guess my question is, what value do you place on determining exactly what type of dementia an individual may be suffering
Early on, when there's memory loss, is when there's the most value in being very thorough. You guys have mentioned earlier, what about hearing loss? What about vision loss? What about depression? What about vitamin B12 deficiency? What about thyroid? What about all these other things that we might be able to leverage? And maybe the person will be better for a period of time. If it truly is an Alzheimer's dementia, it is going to declare itself over time. CAT scans and MRIs aren't overly useful. Not every person with Alzheimer's dementia needs a CAT scan or an MRI. But there's all those little things you think about earlier that I mentioned that you want to at least get those off the list. And a skilled clinician, be it a geriatrician, psychiatrist, neurologist, that really gets a detailed history from family members about what symptoms are being seen, does a little bit of a detailed evaluation, takes a couple hours to do some testing. They can usually get a pretty good sense as to what type of dementia is going on. As for, it's not important anyway, what are you going to do about it? The meds aren't the greatest in the world. Maybe, 35% of people will actually have benefit. And of that, some of it will be an actual benefit. Some people, it will just mean that there's a delay in the progression of the disease. A few more months before they get to the nursing home, things like that. So they're not the greatest treatments around, and they do have, like any medicine, side effects and such. But that being said, in a lot of cases, we do give it a try. See what the response will be to medicines. And there's a lot of others reasons to label what's going on other than whether or not you prescribe medicine? What does it mean to the person, to the family, to your finances, your family structure, to have somebody with dementia in the family? How are you going to plan for your future? So there's lots of other reasons to think about and talk about memory loss and dementia other than just what medicine can be used.
And just another thing about approaching a person, because I also, you know, as you were saying, they know what they're doing. They know perfectly well, you know, they know how to, you know, push my buttons. They don't. I mean, but they, you know, I mean, they're responding, and it's not intentional. The behaviors are more a response to an emotional response they're having to what they're feeling from you or the environment, you know, your internal or external environment. So having a diagnosis helps, as Beth was saying, also helps you plan and being able to work with that person. You know, now I told you this 2 minutes ago. Those kinds of things, you can't. I mean, that doesn't work.
I have a question, but I actually also wanted to say that for me, my father has Alzheimer's and my mother has vascular dementia, and it's helpful to me to have the diagnoses because they're very different looking, and it helps me understand each one of them, and it gives me something to read about and just feel more in control myself. That's for me what the diagnosis helped with. But my question is, I recently in the news, they were talking about that they think that they've had it all wrong with Alzheimer's and what causes it, and that they've actually, the medicines possibly are doing the exact opposite of what should be done, and that they're going to have to do research in a very different way because there was, and so I was wondering if you could comment on that.
I don't know specifically what article you're referring to. There definitely is some research suggesting that the plaques and tangles that we classically blame Alzheimer's on, that it's not so much the presence of plaques and tangles, but that it is more of a neurochemical type of problem. The acetylcholine model that you had mentioned before, and there are autopsy studies where they say, wow, a lot of people actually have plaques and tangles and never actually had clinical Alzheimer's. So it is more than the plaques and the tangles, and there is all sorts of research going on in Alzheimer's right now. It looks like it's still going to be quite some time before we see new treatments as a result of that in Alzheimer's.
I'm Charlotte Otis, and I think that everyone here who's a caregiver should be aware that there is an excellent Alzheimer's support group. It's held the first Thursday of every month in the McCallum building, and it is led by Karen Bassini, who is a psychiatric nurse specialist, and it's an excellent group, and everyone there has been through what all you people are going through. Everyone has a little different story, but they have all been through caring for a loved one, and it's an excellent group, and I think it would be a great help to all of you. And I just wanted you to know that that is available.
I'm going to be the bad cop. We have to end this even though it doesn't end, and it won't end. It's a journey. We're all on this journey. I just want to thank you on behalf of myself and Michael for being here, for caring, for spending this time. I certainly want to thank our very knowledgeable and helpful speakers. And Dr. Beth is going to have the last word. I hope that you all know that we are going to have a dementia care fair on Saturday, April 30th, from 10 in the morning until 5 in the evening, at which all around this room will be people who have services to offer you and your loved person. And all day long, there will be brief presentations and question and answer so that you can find out if you are visiting a table with somebody who represents, for instance, a long-term care facility. There will be somebody here telling you what to look for in a long-term care facility. There will be people telling you what they know that can help you, and you can ask. And again, you are all great resources to each other. The more that you talk to each other and tell each other what you know and what has worked, and just share how hard and frustrating it is, the better the journey is. Thanks again.
I get the fun job of saying the final thank yous. I'm very proud to have been a steering committee member of the Dementia-Initiative from the beginning, and I'm very proud of the work that everybody involved has done. Thank you very much, Eleanor and Michael, for all the work you've done in organizing this event tonight. And thank you very much to each of you. I think this was really excellent information tonight, and a nice variety and progression throughout the night. I hope that everybody was able to get some insights into what dementia is, what it means to the person, how to approach the person, and some thoughts on to how to take care of yourself and actually label yourself a caregiver and try and get some help so you can be healthy as well. And like Eleanor said, I hope you can join us for the Dementia Care Fair that we'll have at the end of April, and we hope to do some more of these community right here in this room, And we hope to do some more community conversations like this in the future. And any feedback that you guys have for us on how to make this a better program or more accessible for you, we'd love to hear that. Thank you.